Good morning, people. I'm not feeling my best lately. I don't know why. I guess it's spring pissing me off, I guess. And hopefully it's gonna be over very soon. But yeah, let's talk about LDN, low dose naltrexone, because it's been like a huge part of my healing. And this is gonna be long, so I wrote it down and I'm gonna have to read it because my memory is not that good. And yeah, so there are very few moments in medicine where an old, cheap or patent drug turns out to have completely unexpected and profoundly important biological effects at a fraction of its original dose. So low dose naltrexone is one of those. Naltrexone at standard doses, like 50 milligrams daily, it's an opioid receptor antagonist approved by, the FDA and so on, for the treatment of opioid and alcohol dependence. It blocks opioid receptors completely and continuously, preventing the euphoric effects of opioids and reducing alcohol cravings. It has been used in addition to medicine since 1980s or so, at 1/10 to 1/13th of that dose, 1.5 or 4.5, taking at night. Sometimes, some people takes it like I do, morning and night, and higher dose is slightly higher, but still low dose. It's a very different thing, and something very different happens. So instead of sustained opioid receptor blockades, the brief transient blockage produced by low dose naltrexone triggers a rebound upregulation of the endogenous opioid system, and the body responds to the brief receptor block by producing more endorphins, more enkephalins, and more opioid receptors. A compensatory response that over time produces a cascade downstream effects that are generally like remarkable. The immune system is modulated, neuroinflammation is reduced, microglial activation, the driver of central nervous system inflammation, is virtually every neurological and psychiatric, if you want to call it that way, which is inflammation condition. It's suppressed, pain sensitivity is altered, mood is improved, autoimmune activity is reduced. So in this plaque of autoimmunity that we're having because of toxicity, this is going to be very, very, very useful. All of this at a dose so low it produces no opioid receptor blockage affecting during waking hours, no significant side effects in the majority of users, and cost approximately $20 to $30 per month from a compounding pharmacy. Sometimes, it depends where you get it. The story of low dose naltrexone is simultaneously one of the most exciting and most frustrating in modern medicine. Evidence is consistently positive across the astonishing range of conditions, frustrating because an off patent drug with no pharmaceutical industry profit potential has received almost no large scale clinical trial funding, leaving the evidence base stronger than conventional medicine acknowledges, but you know, weaker than the clinical experience of thousands of practitioners and patients suggest it deserves to be. So, as usual, follow the money and you'll find what goes on with everything, right? I mean, yeah. What naltrexone is and how LDN works in biology. So, yeah, let's say the parent drug, the standard naltrexone dose, is a competitive opioid receptor, as I said. It binds to mu, delta, and kappa opioid receptors with high affinity and blocks them completely, preventing endogenous opioids, endorphins, enkephalins, endorphins, exogenous opioids, morphine, heroin, whatever, from binding and producing their effects at 50 milligrams daily. The receptor blockade is sustained throughout the day, producing the continuous opioid suppression required for addiction treatment. Naltrexone also binds and blocks the toll-like receptors TLR4 on immune cells, especially on microglia in the central nervous system. Um, this interaction with TLR4 entirely separates from the opioid receptor mechanism is known recognized as central to low dose naltrexone's immunomodulatory and neuroinflammatory effects. So, low dose naltrexone, the rebound phenomenon. At 1.5, 4.5 taken at night, naltrexone produces a brief 4 to 6 hours opioid receptor blockage that occurs primarily during sleep when endogenous opioid secretion is typically at its daily peak. The brief receptor blockage produces homeostatic rebound response in the endogenous opioid system. Upregulation and endorphin production, no? The pituitary and hypothalamus increase endorphin synthesis, that's with low dose, and secretion in response to the transition receptor blockage. Upregulation of opioid receptor density and sensitivity. The body increases the number and sensitivity of opioid receptors to compensate for their temporary blockage, let's say. So, yeah. The net result, taken consistently, is a meaningful upregulation of the endogenous opioid tone that operates throughout the subsequent day, let's say. Endorphins and enkephalins are not simply pain modulators, they are profound immune regulators. With receptors on T cells, B cells, natural killer macrophages, and dendritic cells, producing direct immunomodulatory effects that explain much of LDN clinical activity in autoimmune and inflammatory conditions, which are the plaque, which is what we are all suffering from, let's say. So yeah, microglia, when activated by inflammatory signals, LPS from gut dysbiosis, protein aggravates viral antigens, stress, injury. They release pro-inflammatory cytokines, EL60 and F alpha, and so on. Reactive oxygen species and glutamate that drive neuroinflammation. The central nervous system inflammatory process underlying, depression, anxiety, cognitive decline, fibromyalgia, Lyme disease, especially Lyme, neuropathic pain, multiple sclerosis, Parkinson disease, and virtually any neurological and, all these inflammatory conditions, let's say. TLR4 is the primary receptor throughout which microglia are activated in response to the most common inflammatory signals. Its blockage by LDN reduces the microglia activation, quieting the neuroinflammatory tone that underlies the central sensitization of chronic pain. The neuroinflammatory driver of, depression and the microglia activation to neurodegenerative diseases, let's say. This TLR4 mediated glial modulation is dose dependent in the opposite direction from the opioid receptor effects. Lower doses produce more selective TLR4 inhibition without the receptor downregulation that would occur at a higher dose. This is fascinating, and I'm amazed that someone came out with this to help all the people going through these diseases, because it's just crazy, right? And the fact that, as I said before, they are not properly investigating it, because it would be not, never mind, follow the money again. So, yeah, the combined mechanism, basically endogenous opioid system regulation, improving immune regulation, pain modulation, mood, TLR4 mediated microglia suppression, reducing neuroinflammation, central sensitization, produces a pharmacological profile that is generally unique. No other available drug or natural compound simultaneously upregulates endogenous opioids and suppresses microglia TLR4 activation, and explains why LDN produces clinical benefit across such a diverse range of conditions they share basically immune dysregulation and neuroinflammation as a common biological trigger, let's say. So, yeah, it can be used, as clinical evidence in MS, for instance, is where it's been more studied. All of these diseases would be more or less the same situation. In fibromyalgia, same thing. LDN mechanisms suppress microglia activation, and endogenous opioids directly addresses the two primary drivers of central sensitization. It also helps with, obviously, Crohn's disease. Again, all of these diseases, autoimmune diseases, Hashimoto thyroiditis, LDN endorphin mediated immune modulation addresses the dysregulated immune response attacking the thyroid, let's say, for instance. Multiple cases, serious practitioners report document reducing in TPO antibody levels with LDN in Hashimoto patients. So the LDN Research Trust patient registry documents consistent improvements in joint pain, stiffness, function in RI, for instance, rheumatoid arthritis, in psoriasis, in depression, in anxiety, chronic pain, neuropathic pain, long COVID, or what they call long COVID, cancer, obviously, neurological condition like Parkinson disease, Alzheimer disease. Especially in Alzheimer, there's been a bit more research, let's say. And yeah, LAS, the neuroinflammatory component of ALAS, microglial activation, TDP43 aggregation, as the falling proteosis of motor neurons provide mechanism, So yeah, basically all these diseases anyway, I believe, have the same root cause, which is um, incoherence of the way we live and very high environmental toxicity, horrible diets. All these brings to these diseases, and they are the same thing, affecting in different ways. That's what I believe anyway. At this point, flaring different infections because the immune system cannot cope anymore, creating insulin resistance, blah 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 blah. All this goes together, and then depending on which symptom you have one of these names or the other, because it's going to affect one thing or the other. The body is not silly, it's not going to attack yourself for no reason. There has to be something that make the immune system, let's say, behave in that way. It's not gone mad because of no reason at all, right? But that's another story. Let's continue with Alian. So yeah, the dosing, timing, formulation, and sourcing, the standard approach to LDN initiation, usually starting dose, it's like 1.5 a night, could be lower. The lowest effective dose for most people allows assessment of any initial side effects like vivid dreams. I also believe that this allows your body to produce more glutathione and start detoxing. So having like a urge at the start until you hit the dose is very pretty common. And this is something that people at the beginning do not understand, and then they quit because, you know, which isn't, it's a shame because the relief it brings later on is huge. Especially if the case of neuroinflammation is really high. Like in my case, I've taken much higher doses than that, even though they are still low doses, because I need it. you know, if it's for pain related things and things like this, usually the 4.5 is usually what works for people. So it will depend. You have to take with actually finding a doctor that can prescribe this to you. And you have to start playing with the doses and how often you do it and so on until you find the right one. It's not that we like relying on these things. I wish, that, but at least it's something that's not going to cause any harm along everything else that you do. And I wish I didn't have to rely on it still, but I do because it works. And, I suffered far, I mean, enough, it's such a tiny microscopic dose anyway, even though I'm in the higher part, that, it's really interesting. So the timing obviously matters. Taken at bed now, it's helpful because endogenous opioid secretion peaks during sleep. The brief receptor blockage during peak endorphin secretion produces the most pronounced rebound upregulation. So the sleep timing allows the 4 to 6 hours blocking effect to occur during sleep. So waking hours are spent in the upregulated endorphin state rather than in the receptor blockage. So yeah, apart from this vivid dream situation that you can possibly have at the beginning, um, that'll be it. Some hurting could possibly happen. I call it hurts. You can call it, how would you say it? I mean, in Lyme land, we call it a hurt reaction. It's basically a die off, or however you want to call it. Yeah. So, yeah. LDN requires compounding because the standard naltrexone is only manufactured at 50-gram tablets for too high for LDN purposes. So compounding pharmacies prepare LDN in capsules from the prescribed dose, typically again 1.5, 3, 4.5 in very severe neuroinflammation, neurolyme cases. Uh, it can get higher. Or even twice a day, which I done. So yeah, it will depend. So you talk with your doctor and try to make sure to find the right spot for you. And then later on, which I'm working on, lowering it so you no longer need it, or you keep with much higher, I mean lower dose, and live, which is the whole point, right? Along everything else, diet plays. And but I believe this is like the most revolutionary thing that has happened since all this toxicity, environmental diseases happen. So yeah, again, you have to watch for quality, the filler ingredients. Some compounding preparations use calcium carbonate as a filler. It's a concern as it can bind to naltrexone and reduce bioavailability. Microcrystalline cellulose or lactose is preferred as a filler material by many LDN practitioners, let's say. Stability, compounded naltrexone capsules should be stored in a cool, dry location, used with preparation, and so on. So a reputable compounding pharmacy could help. And yeah, and again, apart from the dreams and some mild nausea and stuff, that'll be basically it with people that are very sick or with neuroinflammation. Again, there'll be some what I call hurt happening because your body, when you lower inflammation, automatically starts detoxing. People believes that lowering inflammation means nothing to heal, and that's not true. When you lower inflammation, your body is allowed to start detoxing, which is healing you. So obviously, when you detox, you're gonna have some hurt reactions as you cannot maybe cope with all the toxins coming out at once, which causes this increases inflammation. So yeah. Um, Again, there'll be some interactions talk with your prescriber, not much really, but yeah. uh so yeah, that'll be it basically, but this is gonna help. Basically, it's a power modulator of immune and neurological terrain. It produces its best result within a bordered terrain restoration approach. So the gut LDN synergy. The gut is the richest site of opioid receptor expression in the body, with the enteric nervous system producing its own endogenous opioids that regulate initial motility, permeability, immune function. LDN endorphin upregulation directly modulates the gut immune environment, reducing the pro-inflammatory intestinal tone that drives both local, Crohn's disease, IBS, and systemic autoimmune inflammation. But LDN, the TLR4 modulation in the gut is only as effective as the gut dysbiosis terrain allows, because TLR4 activating LPS that drives microglial and intestinal macrophage inflammatory activation comes primarily from the gut. A gut terrain with significant dysbiosis and intestinal permeability continuously delivers LPS to TLR4 receptors throughout the body, producing the neuroinflammation, systemic inflammation that LDN is partly counteracting, healing the gut, reducing LPS load by restoring barrier integrity, microbiome balance, remove the primary driver of TLR4 activation rather than simply blocking the receptor while the activation signal continues. So the combination of gut healing and LDN is more powerful than anything alone. Obviously, you need to combine all these things while you are healing everything else. But that's the point. Again, if you lower inflammation, this is going to be a lot easier. So, so yeah, gut barrier repair, that'll be another story. The nutritional terrain in LDN, endorphin synthesis requires adequate nutritional substrates, the same amino acids and cofactor requirements as neurotransmitter synthesis generally, like tyrosine, phenylalanine, precursors to the catecholamine pathway, shared with dopamine and norepinephrine synthesis, adequate dietary protein providing these amino acids, this perquisite for endorphin upregulation. LDN is required to trigger vitamin C, required for hydroxylation steps in opioid peptide synthesis. Inadequate vitamin C impairs endorphin production regardless of LDN stimulation. Zinc, required for the enzymatic processing of opiomelanocortin, into these active endorphin products. Zinc deficiency impairs the endorphin synthesis, that LDN rebound subregulation in, B vitamins, particularly B6 and P5P, required for multiple steps in neuropeptide synthesis and processing. So the practical implication, LDN works by triggering the body to produce more endorphins, but this is upregulation to produce depends on having the nutritional substrates that actually produce them. A nutritionally depleted individual might get less from LDN than someone with fully supported opioid system biochemistry. The nervous system terrain in LDN. Chronic system, sympathetic dominance, the fight or flight state of chronic stress impairs endogenous opioid system function. Cortisol suppresses endorphin production and reduces opioid receptor sensitivity, the opposite of what LDN is trying to achieve. So for people in chronic HPA axis activation, addressing the nervous system terrain through coherent breathing, adequate sleep, somatic therapy, and nature exposure is both complementary to the synergic with LDN endorphin regulating effects. So it works like a synergy with everything else you do. Again, nothing heals on its own, but it's a huge help. The nervous system regulation that allows the parasympathetic state is the state in which endorphin production is most active, and the state in which LD and rebound upregulation produces the greatest magnitude of endorphin elevation. Anti-inflammatory nutrition alongside LDN. LDN reduces neuroinflammation and systemic inflammatory signaling throughout the immune modulatory mechanism, but the dietary terrain that continuously produces inflammatory eicosanoids from seed oil, arachidonic acid that maintains elevated NFKB from carbohydrate driven insulin resistance, and that sustains the gut dysbiosis, delivering LPS and TLR4 receptors throughout the body, continuously regenerates the inflammation that LDN is trying to reduce. So you need to work on the diet, you need to work on the detox, you need to work on all this while on LDN, and while LDN is doing its job and helping you. Nothing works on its own, everything is a synergy and works together. So, so yeah, I mean, basically, low dose naltrexone sites and the most important intersection in modern medicine between a genuinely effective intervention and a medical system structurally enabled to properly evaluate it. The structural problem is simple and honest. Pharmaceutical companies fund clinical trials, and no pharmaceutical company has a financial interest in funding large scale for a drug that costs $20 per month or less and cannot be patented. The result is an intervention with a compelling mechanism basis, consistent positive signals across multiple conditions in smaller trials, and an extraordinary safety conditions in small, in all of them. So it's safe, it's effective, it's cost effective, well, relatively, but compared to other things it does not cause like any side effect problem apart from the healing crisis hurts that you could possibly have. Uh, and it returns to life for many patients that while they do the rest of the work, the diet, the place, the everything else, the nervous system work, deficiencies, and you're trying to heal this terrain. This is gonna give you a huge, huge work, and huge relief, which is gonna allow you to work better with it, especially if you come from extreme, like I was, or severe neuroinflammation, which is gonna allow you, even though it takes a while and a lot of work, to have some brain and and survive these things. It's also very useful again for what they call the personalization, the realization, very typical with Lyme disease, which is the most horrific, absolutely horrible symptom you can possibly have. This is gonna be a huge help. And again, that's all. It's been long. I hope it was kind of understood. I have to read most of it because my memory is just I know it, but I can't. Yeah. So if you have Lyme disease, if you have MS, any of these diseases, or anxiety, all these things, reach out to a holistic doctor, someone who understands all this, and talk to them about this, because there is no necessity to suffer even further. And many times we are in such loops that unless we do something with the inflammation, we cannot treat the person. So thanks for watching. I'll see you next time. Have a good day. Bye.